It's my great honor to have Dr. Raj as my guest here today from India. Thank you for joining me, Dr. Raj.
Oh, it's my pleasure, Dr. Ram. Thank you. Thank you for having me, actually.
Yeah, thank you. This is going to be like a half an hour interview, you know, talking to you and bringing more awareness to our patients and other colleagues. And but I feel like I need 4 hours to go over your bio, so please be patient.
Oh, come on, you humble me. Come on.
Thank you.
Just cut it out. Call me as the cool Dr. Raj.
I'll give people your bio in a nutshell. You graduated in 1997 from dental school in India, correct? And you received your PhD from Sorbonne University in France. You completed your neuromuscular orthodontic training at International College of Craniomandibular Orthopedics, and you received your Fellowship and Mastership, which is quite an honor. There's not very many masters of ICMO around from International College of Craniomandibular Orthopedics. You're also a diplomat of orthodontics from Genoa, Italy, correct? Mm-hmm. And you have received your diplomat from dental sleep medicine in Tufts University, and that was back in 2011, correct? And you were talking about airway. You were looking at connection between airway and TMJ back then. So, and I know it's a big deal these days, and there is many institutions.
You make me feel old when you say back then. it's you know, even when I was in Tufts and I had my neuromuscular training with me, people never understood the relationship between what pain had with the airway issues.
Yes.
Unfortunately. Even now, pulmonologists and your ENTs who treat these patients with airway problems, they don't just see the relationship between pain and the patients that they have the pain.
You know, in fact, this is the first year that American Academy of Orthodontics is recommending orthodontics to pay attention to the airway when they are doing ortho procedures. So that when we're in 2020.
Yeah, I heard about that. So that's a good step. I mean, something's better than nothing. So at least we are moving forward. That's a relief.
Yes, but for those of us that have been treating TMD patients, we always saw that connection, you know, and I'm glad that there is more resources now for helping these patients. So you followed, you know, you got your fellowship from International Functional Orthodontics Association in Italy, and you're currently International Secretary for ICCMO.
Yep.
Correct.
ICMO,
go ICMO.
Yeah, go ICMO.
Yes, and you're also the president of ICMO India section. And you and your lovely wife, Asha, run several right bite centers.
The right bite craniofacial pain care centers.
That is wonderful.
Too long.
That's wonderful. And you have what, 7 locations now? 7 or 8 locations?
Actually, I have 5 centers, and I'm a consultant at 3 other hospitals. So,
that's 8, wonderful.
Yeah, kind of 8 places. So I keep traveling because it's tough for our patients to reach your own center. It's much easier now, but back when I started, like 15 years ago, I thought it would be better if I could get to them, because one thing was awareness. No one knew what this was about, so I was just trying to spread the awareness as I traveled. So it's been a hell of a change from then, and as of now, patients and doctors alike, they know a lot about neuromuscular dentistry. So
but you pioneered. You were the pioneer in bringing K7 evaluation, computerized by jaw tracking, and ULF TENS. We all know the value of stimulating the trigeminal nerve and resetting the sympathetic and parasympathetic system. You're the pioneer in South Asia in bringing that.
Even now, I find that hard to believe, because why wouldn't anyone do it before that, right? Why wouldn't anyone study all of this before I came in? I just don't get it. Even now, universities across the world, not just India, are still talking about same old, same old. So why aren't EMGs being given enough importance? Why isn't the myo trajectory given enough importance? Because neuromuscular dentistry is just about that, right? Making sure the mandible falls into the right myo trajectory after 45 minutes of TENS or whenever the muscles are isotonic. So it's 15 years ago when I was talking about this in India, I was considered a fool. Now I have 70 fools along with me. So we are a growing group of fools. But it's been worth it, the trouble and the hard work. It's all about perseverance, and it's been really worth it. I'm happy. I'm just proud.
What motivated you to travel around the world and reach out to the best institutes that were teaching the most advanced, dentistry? What really motivated you?
Well, I don't think it's just me. All of us, including you.
Thank you.
All of us fellows and masters of ICMO, we've always been the crazy guys, right? We've
Yes,
always wanted to be
crazy.
different. We keep asking the questions, why, how, we are curious. So it's that curiosity that, keeps driving you across the world looking for answers. When I I got into neuromuscular orthodontics through Dr. Fabio. He came to India to have a half-hour session, a lecture at some dental conference, and this was back in 2002. And whatever he said made sense to me, and I was like, oh my God, what am I doing to my patients? I just followed him all the way back into Albenga and Genova in Italy, and I've been with him ever since. And once I came back, I was treating patients in pain. 20% of them was still suffering with pain. They just kept coming back with pain. That's when I understood the importance of airway. And that's how I joined Tufts to do my, residency there in sleep medicine. How important sleep is with relation to pain. Came back, again, started treating all those patients. Even now, 5% of patients come back with pain. Why? Because cervical issues, postural issues. Then I went behind that. Rockabaro and sports dentistry in Acadia University with Dr. Giroux. We're doing courses as well. So I got the MAT scan. We look at posture. So we are always trying to learn something more to make sure that every patient is happy. I mean, come on, we are not God, but the answers are out there. It's just for you to seek. It's I've incorporated the cranial nerve testing for 2 years now, something that I never did, and the results are much more better than how they were before. I incorporated that. Not just the testing, even training the nerves so that they function better, they respond better, so that the jaw positioning is better. So these are just things that you keep learning and learning. And, like I said, we are all in the same boat with that regard.
That's exactly right. When we go to dental school, we're trained as tooth doctors, but then when you start working on real people, not mannequins, you see that the teeth and the jaw and the bite alignment and the jaw joints and the craniosacral alignment is all connected. So as you said, that curiosity, will just motivate you to look at the whole picture rather than just zooming your focus in one area. And I think that's when we really bring a lot of value to the practice of of dentistry.
Oh, why do you think we have just 1,000 members across the world in ICMO?
That's true.
Because those are the only 1,000 that are interested in learning to understand why, right?
Yes.
Everyone else
because it's not easy. Learning it is not
this.
easy. The knowledge is not, just comprehending all that. The connection is not easy, and you have to reach out. There's not a lot of university that.
No disrespect. Yeah.
Yes.
No disrespect to anyone, but you have to come on. I I could never tell a patient to, after doing a filling, adjust with the bite. I could never do that.
Yes.
Not after knowing this especially. So, but that's what most of the 99% of the doctors do across the world. So we got to stop those iatrogenic things as well, and just letting it out there.
That's true, and there's so much demand. I had an oral surgeon actually reaching out to me through Myoaligner from India, and he was really emphasizing on the fact that there is such a high prevalence of patients, probably about 80% of people in India that suffer from TMD, and he's handling it with surgeries and Botox, and he was really interested in the concept of relaxing the jaw and holding the jaw, with Myoaligner in a certain position. So he's trying to learn. And I wanted to ask you, what was your research for please tell us more about your research for ICMO and the nutrition part of it. So I want to know more about the connection, and why do you think there is such a high prevalence of patients, TMD patients in India?
Okay, so we Indians love our lentils. We call them dal, D-A-L. Okay, so there are like 100 kind of types of dals, and if you do not cook them well enough, there is a protein known as lathyrogens, which continue in killing off all the collagen and making all the joints kind of loose. So when Dr. Norman Thomas asked me to do a research paper on lathyrogens and how they affect the TMJ, all I had to do was go through the history books, and there's an entire book written on a specific drought that happened in central India back in the 60s, and how many of them ended up with collagenolytic disorders just because there was not enough water to boil those lentils. So that was my research paper, and I was never good at biochemistry, and Dr. Norm knows everything, so it was tough work. But I'm just happy I did that because I got to learn biochemistry. So now I understood the 80% of the why, so just a little 20%. It's like I said, you're always learning. So that was my research paper. But most of the times when I teach at my courses in India, when I talk about my research paper, there's hardly any interest evinced, because finally the dentist thinks, how am I involved? They still don't understand why we as dentists were taught. Okay, when we were in first year of dental school, we were taught anatomy of the head and neck, the physiology, and in second year, you write the exams, and in your second year you learn pharmacology and general pathology and general medicine. So when you get to and then you write the exam, you pass that exam. When you get to the final year of your schooling, all you learn is your dental subjects.
Yes.
And you've forgotten whatever you've learned in the first 3 years. So that's what happens to dentists, I believe, across the world. They only then, for the rest of their lives, all they remember is what they've learned in the final year of dental school, which is the dental subjects. So that's all right. You need to know your biochemistry. This is why you need to know your biochemistry. This is why you need to know your physiology. This is why you need to know your anatomy more than anything else.
Yeah.
But dentists are just learning just the dental part of it. That's not enough. Now, we've never been taught about the TMJ in school. I mean, define the TMJ. That's about it, right?
Yes.
We were taught to use deprogramming splints. Talking about, okay, can I just add? I'm sorry, I just talk a lot. You know me.
No. I remember we had textbooks classifying the disorders of TMJ, but no solutions.
Yeah.
The solution was like half a page.
Exactly.
But
you try everything on the patient, and then so when we were learning about the TMJ and how to treat them, we were asked to give them deprogrammers. Now, this is something that I've also been thinking. Now, why the term deprogramming? Because all that we were doing then were CR or Pankey or anything that we were doing were always deprogramming splints because we did not know how to reprogram.
Exactly.
So right now with the technology that we have, we know where exactly the mandible has to come to. So we know the precise point how to reprogram, not just deprogram. Flat splints help them deprogram, yes. And then they go back into the old program again. No, you got to reprogram them. And the answer to that is neuromuscular dentistry. We know where exactly to reprogram them. So most people don't understand, why you call them reprogramming and not deprogramming. This is the reason why. It's as simple as it is.
That's true. And I think the key is in the orthotics that we make, because the deprogramming is done by a splint, which is non-functional. It maintains the homeostasis, and it doesn't let you chew and function and swallow correctly. It just discludes you from a pathological occlusion, kind of like having a calloused toe and just lifting your toe and not using that toe. So you're not using it for function.
Yeah.
But we know that we as human beings need to function. We need to chew and swallow and get these muscles to work. That's why we're in the trouble in the first place, because we haven't used our muscles correctly.
Yep.
So I think the key is the orthotics, the fully anatomical orthotics that are used by neuromuscular dentists that guides the mandible to that physiologic trajectory, and the endpoint being a physiologic bite. And I've had several discussions with dentists, that are not get this concept that we need to stabilize the mandible. So that's a huge point that you brought up, and that's the big difference between physiologic dentistry and neuromuscular dentistry. We reprogram our patients and we let them chew and function.
Yep.
Yes.
That's a term. So and reprogramming also has to be followed by cervical manipulation, postural changes.
Exactly.
For example, we use MAT scan at all our, have you heard of the MAT scan? Okay, it helps you calculate your sway analysis and your a weight gain, depending on which side you're swaying to. With every change in your bite, there's a change in that. So we use the MAT scan, especially for our sports patients. We use those enhancements appliances, and people don't understand how important chiropractic is. So chiropractic is virtually absent in India. It's not there. It's not there at all. It's not there. I believe there's a strong lobby against them. Because they kind of help some patients at least. So we have one in each of our offices because there is one in each of these cities that they work in. So we are fortunate in that way. But because they are not prevalent enough in India, we really struggle. I really struggled in my first 10 years of practice. I've been finding this chiropractic only in the past 5 or 6 years. I've never seen before that. I remember once when I was in Calgary, again, to learn, to know more about chiropractic, I had visited Dr. Jeff Schulten's office when I was with Curtis Westerson. And Jeff was doing the most amazing work on these patients. And immediately after, when you check the patient on the K7 and with the EMGs, you see that much of difference in the bite position and how much more effective those bite positions are on the patient. And now, especially with our MAT scan, the chiropractor comes to our office to physically see whether there is a difference or not. So it's amazing. Technology, we just, and I'm a boy. I love my
technology
toys.
is just proving, you know, what we've been seeing in our patients, and technology is just documenting and giving us more data, kind of like a CT scan, which is three-dimensional versus a radiograph. We can get a lot more information from that 3D. So it's amazing, you know, that the technology is helping us with our diagnosis. And you brought up a great point that the postural alignment and the bite alignment is the key. And it's amazing to see when you have good postural alignment and good nervous stimulation and blood flow to the whole system, it not only helps you physically, but emotionally, mentally. You know, our motto at Myoaligner is balanced bite, balanced life, you know, because it can all start with a little malalignment in the body that can just throw off your whole balance. That's why our TMJ patients are so crabby sometimes, you know, they're just, they've had so
Can't blame them. Can't blame them. Can't blame them. So when these patients come up, they just come up and start crying. I said, don't worry, we understand. And they just feel so happy when you tell them we understand.
Yes.
Because no one else seems to understand them.
Yes.
You know, at least 80%
they get
of
mad
all
that
our
people are saying this is a psychosomatic issue, because oftentimes
they virtually turn mad. They become mad because they're converted into that. You know, none of the MRIs and the CTs that the other doctors are looking at, they don't concentrate on the airway or on the TMJ, and that's how these patients, you know, end up at the psychiatrist's office. So that is sad, actually.
Yes. So for those of us who've been practicing like 2 decades on neuromuscular dentistry and finding the right position of the mandible, but at some point we got stuck with the size of the maxilla, you know, and then that's why we're like, no, now we need to really improve the size of this maxilla to really open up the airway and the sinuses and help our patients establish nasal breathing. And, so that's amazing to see more connection between TMD doctors and airway doctors. And I'm glad that you're pioneering and bringing all this. I understand that you brought Vivos to India. You were the first one bringing Vivos, more awareness through that company. I'm not saying they're the first ones, you know, that are talking about airway and TMJ, you know, but they're the first huge organization, you know, that is really pushing
the knowledge. I mean, we need people, we need companies like those. We can't be anti-corporate, just because you don't believe in capitalism. But it is required, because I alone as a human being, or ICMO as a non-profit organization, cannot, we don't have the resources to push the knowledge across, and we was just bridge that gap. And I'm really happy that I got involved with them. And again, the problem with India is always being the financial constraints, right? So ever since I've started treatment, helping our patients in India, I've been trying to find the right balance. For example, when someone in the US would charge $5,000 to $8,000 for phase 1, we in India charge $400 to $500, like a zero less.
Wow.
So that
doesn't even cover the cost of appliances here in the US.
So anything, even the K7. So every time I was trying to bring in something to India, the first thing I do is connect with the company and bargain. Because it's not going to happen in India, you know. And I do not want to I've never got into doing cheap, replicas of the main thing, because they never work, okay? I've had friends who say the DNA appliance never works. I said, okay, which lab have you sent it to? Oh, my technician does it. Oh. He's not going to do it. It's not happening. You cannot blame the appliance for just because your technician made it. You know, that's not right. You have to have the actual thing.
Yeah.
So it's always been that's always been the hassle, to get people in the West to understand the subcontinent, how the system works here, and it's more about volume and numbers. financially speaking.
Well, I really admire you for swimming against the mainstream, you know, and doing all of this. I know you've traveled around the world. As you said, you bargain with these companies. You try to bring the best technology, you know. And even when we're talking about Myoaligner, you know, you ordered a few Myoaliners, you know. You were one of the early adapters a few years ago, and I know what you paid for it is probably more than what you charge the patient. So I really...
Well, yes, I did. And I haven't given up on bargaining with you yet.
Okay.
I'd like to point this out. I've been to 89 countries.
89 countries. Oh my gosh, that's amazing. Yes. And it would have continued if it wasn't for this pandemic.
Yeah, I was looking to 100 by the end of this year.
We should have been in Calgary in a month. You know, I was looking so forward to seeing Banff at Calgary, University of Alberta. Yeah, so for our ICMO session.
Missed that. Well, I hope to be in New York. I really hope that works out.
The great, I don't know. I know I got
international. International.
Yes.
New York. So 2023 is ICMO India. So you better be there.
Oh, I would love to. I would love to sponsor and be there. But, you know.
Oh, wonderful.
Luckily, we have the technology, you know, even though we're physically distancing, but we're not socially distancing. We can still keep connected, you know, and so I
Zoom
really
has bridged the gap.
Pardon me?
Zoom,
yes.
Bridges the gap.
Yes. Yes.
So, Mariam, how long have you been into neuromuscular? Sorry, I mean, I don't want it to be a reverse.
Oh, yes. Actually, since I graduated from dental school, I graduated in '98 from Oregon Health Sciences University. I was a top honor student, but I had TMJ problems myself.
Oh, that's how. Okay.
Yes, yeah. Unfortunately, I was a victim of abuse.
Most of the doctors...
and I had injured my TMJ, so that was tough, you know. And as you said, even my instructors at the oral surgery department just made me a splint, and that was the end of my treatment. And I started
a deprogramming splint.
They deprogrammed me.
Deprogramming, not
but
a reprogramming.
No, I want to be able to function. I don't want to depend on this appliance. So so that's when I started with Frank Spear, you know, now it's Koizen, Spear Center. So that was in Seattle. In 20 years ago, I started learning about occlusion then, but it was mostly about aesthetics and occlusion that's attached to an articulator, not to a patient. And your anatomy, your jaw anatomy, and my jaw anatomy is completely different, and we cannot have one $2,000 articulator per person. So
it's like how people still follow the Gelb 4x7 position. I have my reservations to that position because not every human being would be happy with 4x7. What if my condyle wants to be in the 5th position or in 6th position? That's where the muscles decide them to be, right?
Exactly.
And again, depending on the anatomy of the fossa, but you know, if you don't get into too much technicality, I think the muscles are the ones that need to decide where the jaw position is.
They're driving.
And that's the advantage with the TENS unit, because there's yaw, pitch, and roll. All three are controlled. With the other techniques, you're not controlling the yaw and the pitch. I mean, yaw and the roll is just the pitch. You know, you're assuming the yaw and the roll. Yeah.
And you know, in dental school, we learned physiologic rest in dental school when we were making dentures. Physiologic rest was where the muscles of the mandible are at rest. So why did we forget about that? You know, and that's the
How do you get there?
Pardon me?
No, the question is how do you get to that position?
How do you get to the physiologic rest position? Yes.
69 and 66 or what? 65, 62.
Yeah, exactly. And then, so, you know, I think neuromuscular dentistry is or tensing, the ULF TENS that you brought to India is the key to get to that physiologic rest position of the mandible. Once you know that position, then you know where your physiologic bite should be, and the rest will just follow. Yes, and then now you know with solutions that we have for the upper jaw, then we can match the maxilla to that and improve the airway and posture, all of that. But it's the physiologic rest that everyone has forgotten. And I think the reason behind a lot of these deprogrammers that you mentioned with the flat plane appliances is they're hoping to get to that physiologic rest position, but it can take months when you're just adjusting that appliance. We can get to that position in 40 minutes with a
day one.
Yes, day one we can get to that.
Day one. Yeah.
So
a lot of my colleagues who are not into neuromuscular, prosthodontists maybe, they keep asking me, why are you so against CR or Pankey or coils or anything? I said, I'm not against. Who said I'm against? I'm not against. If you are sure, if you are measuring that CR position, if the muscles are happy there, great. I just want you to be sure. Okay. Neuromuscular dentistry is not always about gadgetry and biometrics and measurement only. It's mainly about the myotrajectory.
Yes.
Exactly. And any treatment that gets the mandible to be in the right myotrajectory is neuromuscular.
Yes.
Exactly.
I mean,
that's what,
exactly.
Yeah. So there's a lot of companies out there, and we have the T-scan, we have the DTR that's involved. I do a lot of DTRs on my patients. At least 20% of my patients undergo DTR as per the protocol that we follow. We have the right bite protocol, so we have divided the patients like a guideline, especially for our students, into addition NMD and reduction NMD.
Mm-hmm.
So if the vertical is less than the golden vertical, then we need to add. So we give orthotics, so it's addition NMD. If it's the other way around, it's reduction NMD, and we go to DTR.
Yeah.
So that's how I help guide our students who are learning the science. So DTR, the process itself, is all about the whole protocol. Is like you come after 2 weeks, you come after a month, you come after 2 months. So why are there these intervals? Because the jaw, after the first set of corrections are done, the jaw relaxes, that comes downward and forward. Then again, the next one downward and forward. So once the patient is pain-free and the EMGs are all isotonic, the patient is on the myotrajectory.
Yes.
Which you can get on day one. So the DTR that the protocol that we follow in our offices in India are, we incorporate the J5, which is the TENS, to the DTR on day one, and that's it.
Yes. Yeah,
So,
that's the key. Finding that trajectory is the key. Whether you're doing restorative work, whether you're doing full mouth reconstruction or doing orthodontic work, you need to find that physiologic rest position of the mandible. You need to look at that airway, and then set your foundation on that. You cannot just change the occlusion and just ignore them mandible and maxilla. Unfortunately, a lot of
people have also been giving a lot of crap to sorry for the language, a lot of nonsense to neuromuscular dentistry by saying, there's a lot of second phase, right? A lot of costly, expensive restoration work that needs to be done. No, absolutely not. I believe in orthodontics. If the patient has teeth, I don't care what the age is, it's orthodontics all the way. Because, like I said, TMD, or I'd actually say CMD now, not TMD. Mm-hmm. It's more cranio-mandibular disorders than just temporal. Yeah. So I always use the word cranio now. Craniocervical, actually, CCMD, to be more specific. Anyway, so most of these CCMD, CMD patients have a narrow maxilla. So just doing build-ups are not going to help the patient as long as you don't expand that airway. So there is going to be the requirement of some sort of orthodontic work, expansion work, on that maxilla or even the mandible to a slight extent to help that patient, so that there's no relapse of the problem again. And even if it's total construction, we have DSD, digital smile design. So we incorporate neuromuscular dentistry with DSD, and the results are amazing. The patients are not just functional, but they look beautiful.
Yeah.
I've been in, I've been to the Well Clinic in Sao Paulo in Brazil, and I've met with the DSD people there, and we've done the courses there, and we're incorporating all of that into our neuromuscular patients. So it's been good. It's been good.
You're absolutely right. One of the main criticism that neuromuscular dentistry was getting is that we were developing long teeth, or patients had to do like full mouth restorations to maintain that position of the mandible. And honestly, that was one of my main motivation in coming up with Myoaligner, the segmented orthotics that are removable, because I went to LBI and I saw a lot of value in fixed orthotics that we delivered. Compliance was great with them. Patients could chew and function as opposed to a acrylic removable appliance. And but then at the end of the day, I had a hard time getting our orthodontists to segment that orthotic that was bonded, and to gradually move the teeth to that position. And they were interested, but it just didn't work because that orthotic is bonded and locked to the teeth. And in some cases, I feel like the patient had no choice but to do restorative because we couldn't do the ortho. And that's why I was thinking, why can't we make that removable? And as you know, we started looking into the technology.
And segmented.
Pardon me?
And segmented.
And segmentation, because we didn't want to flex that mandible during the
True, that
flexion of the mandible.
That's why I love the Myoaligner more than anything else. It's about the torsion, the possible torsion in that area, where if you segment it, it's just. I wonder why no one else thought about this before.
When I gave that lecture in 2017 in Seattle, I was so nervous. Yeah. I thought after that lecture, people like Ira Shapiro are going to come and say, we tried this 50 years ago and that didn't work. When Ira Shapiro talked to me after that, and he's like, that's the key, and I think I have the right patient for you. And he said the key is the segmentation because of the flexion of the mandible. And he reminded me of research that was done in the implant world, that they were placing implants from 18 to 31, and with a full bridge. And those implants were failing because the bridge was solid.
Because they were on a single
thing. Implants were coming out of the bone because of the flexion of the mandible underneath. And Ira Shapiro said, in some cases when he was not getting resolution on a full arch appliance, he would just segment the orthotic in half. And after a few days, he saw a big gap on that orthotic. And the patient was like, oh, now I'm relieved, there's not much pressure. And so it was such a great, assurance for me that I was on the right path. We haven't even started Myoaligner. We didn't even have a full company. And, but after that lecture in 2017, I was even 100 times more motivated to really look into that. And as you know, you've tried it too. We're building crowns to teeth that are not prepped. So we have undercuts to deal with. So with the appliances, we're even too tight or too loose. And just like any other, inventor or entrepreneur, I went to several local labs. At first they look at the Myoaligner, they're like, oh, this is easy, I can make it for you. 1 week later, they're like, my wife is gonna divorce me. I've been working on this. They're like, I've been working on this for a whole week and it's either too tight or too loose, so, but.
It's all about the designing.
Pardon me?
It's all about the designing. It's all about the designing.
Yes, it's all about the
Yeah,
design.
so
I had to really reach out to the best, CAD/CAM designers, and not only the CAD design, but also milling strategies to just so we don't have to adjust these appliances. And I'm really happy that I see every case, because I do all the quality checks at Myoaligner now, and we're finding more and more doctors are interested. So I need you guys' help to start teaching this now.
come on. Yeah, absolutely. I mean, every time I do courses, I keep talking about Dr. M and the Myoaligner. always, because come on, we're proud to have you as our friend and part of the ICMO. I'm just waiting to see your research paper for the mastership, the one that you were talking about to me.
It's actually coming. Yeah. And the reason I have delayed it is because I have reached out to several providers that have provided Myoaligner, and we want to have a big volume of numbers. What is the efficacy of a segmental orthotic on relieving TMD patients? So we will reach out to you too to kind of like give us before and after.
It's always better to be, well documented than try to hurry up the process. So take your time.
Exactly.
It has to be the best, and only you can do that as well as it can. So looking forward to reading that.
Thank you. The biggest volume I think I have seen is Dr. Barry Cooper's, research paper that was done on 300 patients, that improved with a neuromuscular appliance. That's a nice number. So hopefully we can come up with 1,000 patients, a big number from different providers.
ICMO together can.
Yes.
It's just no one's taking the initiative. So someone has to take the initiative. They'll have to put aside like 6 months of their time, just to come up with something like that.
Yes,
so
collecting all the data, organizing it, presenting. So I'm really excited. We're working on it, definitely working on it, and we'll reach out to you to provide some research.
Cool, absolutely, no time, no problems at all. As the secretary of ICMO International, I'm just trying to spread the word. Every country should have their own section. Every region should have their own section. My dream was to have, to start at least 2 new sections every year. Unfortunately, the stupid pandemic came along, and it's just my dream just stays there. But I was, we were planning to open one in Iberia, Spain, and Portugal. We plan to open one in South Africa. And one in Southeast Asia. But none of that happened. So hoping for the best.
We will get there. We will survive. We'll survive. We'll pass this pandemic. We'll handle it. And in the meantime, we'll just connect with each other virtually. Thank God we have this technology to connect. And we don't have to write each other letters.
True.
Well, thank you so much for your time this evening. It was very nice to have you. It was an honor to host you, and
thank you.
I'm sure our listeners would really enjoy this interview.
Oh yes, thank you very much. Thanks for hosting me. In case anyone has any doubts, they could mail me. My website is tmjindia.com. It's as simple as that. So Perfect. If there's anything, you can get in touch. No issues. Thank you. Thank you again, Dr. M. Regards to the family and your team.
Thank you. Same to you. Same to you. Bye-bye.
Bye.